So even common disease we come to in our day-to-day practice, like diabetes mellitus, hypothyroidism or hyperthyroidism, and collagen vascular disease or Addison's disease. They are, all can lead to malabsorption. So clinical features we all know, malabsorption will present as a diarrhea, often steatorrhea. Steatorrhea means increased fat amount in the stool. So stool will be lighter in consistency. It will float in the toilet. It will not easily flush due to its light weight. Fat is always lighter than the water. So it will all will come on the surface. So in steatorrhea, there is increase in stool fat excretion of more than 6%. So by test, we also diagnose. We give 100 grams fat daily for 2 days, and the next slide is like that. So if it is 6 gram per day excretion of fat in the stool, that means it's not being absorbed well. So it is, we said steatorrhea is present and malabsorption is present there. So there is large, loose, pale, bulky, foul-smelling stool is there that float on water, and there is also complaint of this due to high fat in the stool. So large intestine, it will be swollen. So there will be bloating, flatulence, and abdominal discomfort. There is, in kids, there will be, due to malabsorption, there will be weight loss. There will be growth retardation, failure to thrive, and delayed puberty in children. There may be swelling or edema. There may be anemia, muscle cramp, and because along with fat, vitamin A, D, E, K, all these are also deficiently absorbed. So there is deficiency of these fat-soluble vitamins. So there will be problems in the, also calcium is lost. So calcium, like vitamin D, it may lead to osteomalacia and osteoporosis, also muscle cramps. K, vitamin K, so bleeding tendency may be found there. So test to diagnose malabsorption, we have to look for the steatorrhea, because primarily patient comes when there is malabsorption of the fat. So either quantitative test or qualitative test. Qualitative means just fat is present or not. So we will go for Sudan 3 staining. If multiple droplet of fat is present on the stool examination, so it will confirm our diagnosis that there is steatorrhea. So it constitutes a positive test result. Or quantitative, I told you, if more than 6 gram per day in 72-hour collection of fat stool, if more than 6 gram per day is excreted in the stool, after giving 100 gram of fat per day for 2 days, so it will confirm our diagnosis. So another test is acid steatocrate, which is also very sensitive, 100% sensitive, and specificity is 95%. Another good test is NIRA, near infra reflectance analysis. This is high class, these tests. Just to tell you about this. Another is test for the pernicious anemia, intrinsic chilling test. So cobalamin B12 malabsorption. It helps to assess if absorption is normal, B12. If there is no deficiency of B12, that means our pancreas, stomach, and esophagus are their normal. Ileum is normal. So they are functioning well. If there is lack of this deficiency of B12, that is due to abnormal cobalamin absorption. In cases of chronic pancreatitis, pernicious anemia, achlorhydria, that means stomach involved, bacterial overgrowth, that means colon involved, ileal dysfunction. These all can be tested compositely by single this test. So cobalt 58, which is radio labeled cobalamin, is administered orally, and urine is corrected for 24 hours. So we'll check for the radioactivity in the cobalt in the urine. So before that, we have to saturate our sites in the body. So urinary excretion of bile, it will reflect the cobalamin absorption, provided the intrahepatic binding site for cobalamin are fully saturated, fully occupied. For this, we will give injection of B12 after 1 hour of the oral radio labeled cobalamin. So after 1 hour, we'll give 1 milligram or 1000 microgram B12 injection. It will saturate the liver site, and radioactive cobalamin it will appear in urine. We have to test there. Less than 10% excretion 24 hours, it is abnormal. That means body was deficient in B12. So it will retain in the body, it will not come into urine. If it is by giving injection, it is saturated. That means already patient was not deficient in. So test to diagnose malabsorption by hydrogen breath test. These are high quality tests, so just you should remember it. So hydrogen breath test for lactase deficiency. Give lactose and do basal breath hydrogen test. Sole source of hydrogen in the mammals is bacterial fermentation. So any unabsorbed lactose will go to bacteria, it will digest it there in the lumen itself, and it will release the hydrogen. So if it is not absorbed, then it will be digested but break down by the bacteria there, and it go to stool, but it will release hydrogen. So any hydrogen in the breath, we'll do first basal test before giving that doing test. Basal H2 level we'll see, and then we'll after test. So like that it will suggest the lactose malabsorption. A late peak means lactose malabsorption. If early hydrogen peaks come of 20 ppm, that means it is bacterial overgrowth. So by this we can diagnose. So hydrogen breath test, early peak and late peak. Late peak means lactose intolerance, and early means there is bacterial overgrowth. Another test, urinary Dexylosis test. So 25 Dexylosis, which is completely absorbed. If it is go to stool, less than 4.5 gram excretion primarily reflect the presence of duodenal jejunal mucosal disease. So it can be, it is to be seen in the urine. If it is absorbed well, it will go to urine. If it is less than 4.5 gram per day is gone to urine, that means it is not completely absorbed. So it indicates the malabsorption. Similarly, in blind loop syndrome, it will not digest. Due to multiple diverticula, it may not be completely absorbed, so it will not come to urine in the full amount. So another is for pancreatic insufficiency, just name secretin stimulation. Very old, we were reading about this secreting. Injection is given, we will collect pancreatic juice and analyze it for enzyme levels. And another nowadays fecal elastase 1 test. So fecal elastase 1 level to be seen in the stool. If it is there, then it's equal sensitive to secretin, because secretin is invasive test. We have to go injection first, then we have to put some Ryle's tube, you have to collect the pancreatic juice. But in fecal elastase test, we have to see. If it is there, then it is diagnosing for moderate to severe pancreatic insufficiency. Similarly, for protein malabsorption, look for the alpha-1 antitrypsin clearance. If it is present, that means it has not been absorbed. Protein has not been digested well, and it is going to stool, because this is usually not present in stool. And similarly for test for bacterial overgrowth, if there is 10 to power 5 CFU in the jejunum fluid, that means there is bacterial overgrowth. So another test is endoscopy. It will give you direct results like Crohn's disease and celiac disease. In Crohn's disease, last lecture we told you, there will be cobblestone appearance. So it denotes us there is Crohn's disease. If there is reduced duodenal folds and scalloping of the duodenal mucosa, it indicates celiac disease. So another test is biopsy. By biopsy we can diagnose Whipple's disease, beta lipoproteinemia, Crohn's disease, celiac sprue, tropical sprue, or bacterial overgrowth. All these can be diagnosed by the biopsy. Similarly, barium studies. We will show you the pics. So a small bowel series to be done, and it may denote us. It may give us clue whether if there is tropical this one sprue or there is celiac disease. So in short, suspect malabsorption, we are suspecting malabsorption in a patient, we will first look for the infection causes. Stool for OA and parasite, their antigens are by PCR. If it is positive, we will treat for infection and patient will have clinical relief. If it is negative, we will go for the stool fat test. If it is absent in the stool, that means fat is not at fault. Fat absorption is not at fault. Probably carbohydrate or lactose is malabsorption. So evaluation of watery inflammatory diarrhea, we will see later. So abnormal, if it is stool fat is positive, there may be multiple causes, either pancreatic cause or there may be rapid transit or there may be bacterial overgrowth and suspicion of mucosal disease. All these can lead to malabsorption syndrome. If proximal gut is involved, probability celiac antibody test, we will go for that. And duodenal biopsy is helpful. In distal, you have to go do CT/MR enterography. So this is pick for this normal individual. We see the normal. Radiologist will give us the result. So he will diagnose it and give us the result. And just to show you how it will present, so jejunal diverticula, multiple diverticula filled with the radio contrast barium dye. And celiac disease, you see this picture will be like this, and Crohn's disease, there will be regional. This was localized patches will be there of the villus atrophy. So differential diagnosis, we know tropical is true. There will be, first malabsorption is to be established whether there is malabsorption or not, exclude other causes, and by biopsy we will see the villus atrophy. In celiac disease, very common condition and in pediatric side, and definite test is tissue transglutaminase test. So TTG antibody is to be seen. If TTG antibody is there, then this tissue transglutaminase will not work and there will be malabsorption of the fat. Triglyceride will not be digested. Another is by bowel biopsy and clinical response to gluten withdrawal. गेहूं उसका बंद कर दो, चपाती बंद कर दो. This will not only clinically improve the patient, but also histologically and hematologically improvement will be there. Biochemical improvement will be seen there. If there is parasite, again by stool or jejunal fluid aspiration, you make film, look for the bacteria, parasite, and treat accordingly. Or you go for small bowel biopsy. You can see our fecal antigen for Giardia. You can see for that. If there is bacterial overgrowth, I told you there will be low serum vitamin B12, and which can be tested by hydrogen breath as just now discussed, or quantitative culture for the bacterial overgrowth. In pancreas, again we will see the increased fecal fat. So all these conditions are very common. In celiac disease, now very common condition, you should know some broad outline of the celiac disease. It is an inflammatory disorder of the small bowel. It is occurring in genetically susceptible individuals. So there is intolerance to wheat gluten. So गेहूं उसको पचेगा नहीं बच्चे को. Even it can develop later age also. So it's not that only in fact will our younger age will develop this thing. So there is intolerance to wheat gluten. It will result in the diffuse damage to proximal small intestine and mucosa, and it will lead to malabsorption of nutrients. It will respond to gluten-free diet. So this is very diagnostic and typical, both diagnostic as well as therapeutic. Any patient you come, you can at least on the OPD basis, you can stop his gluten. So he will respond. So there is worldwide distribution. Any age is affected, first year through the 8th decade. So 70, 80 years person also may be affected. It's not that at initial stage he was negative for this. It can appear at any age. So there are three factors which can contribute to this disease, either environmental, immunological and genetic factors. So celiac disease, again gluten peptides are coming through the epithelial cells, and there is tissue transglutaminase just below the epithelial mucosal lining. You see tissue transglutaminase is present, which will deaminate this gluten peptide, and it is taken by the APC, antigen presenting cell, and it will go direct the CD4 cell, T cell, and it will make the inflammatory markers, interleukin 1, interferon, and TNF alpha, and they'll induce the lymphocytic infiltration. So there will be autoimmunity developed there, and it will pro-inflammatory cytokine. It will cause lymphocyte infiltration and will lead to crypt hyperplasia and villus atrophy. So celiac disease can present at any stage, infancy, older age, and adults, and all symptoms are same: diarrhea, dyspepsia, weight loss. In children, there will be delayed growth and delayed puberty and short stature. And features of malnutrition will be more in elderly children, older children, and in adults. Most common in female in third, fourth decade. So they may come with the symptoms of tiredness and weight loss. There may be oral ulceration, and folate deficiency or iron deficiency may be present. There may be extraintestinal manifestation of celiac disease also. So there may be rash, dermatitis, herpetiformis, or neurological problems, neuropathy, ataxia, epilepsy, psychiatry. So CNS problems are there: depression, paranoia, sometimes hepatitis and pancreatitis, reproductive disorders, short stature. HLA-linked autoimmune disorders may also present along with the celiac disease. So diabetes mellitus type 1 or IgA deficiency, autoimmune thyroid disease, pernicious anemia, myasthenia, Downs, Turner's, Williams, all these can be associated with the celiac disease. So this is the normal jejunal mucosa and subtotal villus atrophy seen in celiac disease. And after gluten-free diet, again it will regenerate, it will try to come to back towards normalcy, and patient will be free of disease. So celiac disease, so anti-TTG, it is tenfold there. Also another good antibody test is EMA, that is endomycelial antibodies. They are virtually diagnostic of this and is quite specific, 95 to 95% for active celiac disease. And duodenal biopsy, it is diagnostic, and improvement symptom after gluten-free diet. So this is diagnostic and therapeutic as well. So there is chances of development of cancer because intestinal cells are also, T cells are at fault, so they can go into development of lymphoma, T cell lymphoma. It is a complication. So treatment is gluten-free diet for lifelong. Our lactose-free type sometimes is associated lactose intolerance is there. Then lactose-free diet also to be prescribed to these patients, and give supplement. So calcium, vitamin D, and bisphosphonate therapy in case of osteoporosis and osteomyelitis. Vaccination, because they are already weak, they can develop infections very well, very easily. So you have to vaccinate them as a preventive therapy. Another thing is common reason for failure to improvement is accidental or unknowingly they are consuming gluten products. So if patient he fails to respond, corticosteroid may be given. Another common condition is tropical sprue. So this is poorly understood syndrome which affect both the native person and people coming from another country. So it is so common that it affects 5 to 10% of population in some tropical areas. And again manifestation are same of malabsorption. There is diarrhea, steatorrhea, and weight loss, and there is nutritional deficiency both of folate and cobalamin. And pathogenesis is uncertain. Intestinal biopsy is characteristic. It shows subtotal and patchy villus atrophy. And the symptoms revert to normal in these people when they go back to their origin. So when they return to temperate area, they will be symptom free. So it is diagnosed by history and documentation of B12 or folate acid deficiency, and intestinal biopsy is a must to diagnose it. And treatment, again, give antibiotic course, tetracycline or doxycycline, replace the folic acid and B12 injections to be given if there is B12 deficiency, and less may occur in 20% patients. Short bowel syndrome not for you. So bacterial overgrowth syndrome. So we already discussed in this class. So there may be diarrhea and steatorrhea and macrocytic anemia, and there is common feature is colonic type of bacteria within the small intestine. Development of colonic bacteria in the small. Normally it is not there. But if it then by gastric aspirate or duodenal aspirate, if we go for culture, colonic type of bacteria may come in there, and this is will prove our diagnosis of the bacterial overgrowth syndrome. So there may be, it may be due to stasis caused by the impaired peristalsis. There is functional stasis or anatomic stasis because of sometimes gastric surgery is undergoing, or some we are doing anastomosis. Such patient may develop bacterial overgrowth syndrome. So coliform organism count is in small intestine, it never exceeds 10 to power 3, but in these patients it may rise to 10 to power 8 to 10 to power 10. And because there is bacterial overgrowth, which they will ingest B12, but they manufacture folate. So low B12 and high folate level normal in a person who is not being given any folic acid. So this will prove our diagnosis, or this will confirm our diagnosis of bacterial overgrowth syndrome. In tropical sprue, both are low, but in bacterial overgrowth, folates are high. So this is clue is low serum B12 and elevated serum folate levels, and colonic type bacteria and jejunal aspirate. A barium study, it will confirm our diagnosis, and duodenal biopsy, it will confirm our diagnosis. So abnormality conducive to bacterial overgrowth, all you know, structural when we are doing anastomosis, motor diseases like scleroderma will cause functional stresses, diabetes mellitus, gastroparesis, we know it, and paralytic ileus, all these can lead to bacterial overgrowth. Hypochlorhydria, as in case of atrophic gastritis, are due to proton pump inhibitors, they may lead to malabsorption syndrome. And immunodeficiency states, pancreatitis, cirrhosis, chronic renal failure, all these are causes for bacterial overgrowth syndrome. So treatment is acid, PPI should be stopped because they may cause bacterial overgrowth. Acid is normally usually preventing bacterial overgrowth. In cases of achlorhydria or hypochlorhydria, patients complain with bloating symptoms. So malabsorption, due to malabsorption, because this is killing the normal bacterial organism in the colon, so they may kill these, and normal homeostasis is disturbed. So it may lead to malabsorption. So empirical antibiotic nowadays, rifaximin is available, tetracycline, doxycycline, cipro, augmentin, cephalexin, metro, blah blah. So any antibiotic you can try. Welcome, madam. So if frequent symptom, then you can for 1 week therapy every month, and patient will be free of this bacterial overgrowth. Sometimes there is prokinase drugs may be given, or octreotide in patients with the scleroderma patients, and ADEK should be replaced. Sometime in hypogammaglobulinemia, you can give immunoglobulin transfusion. Whipple's disease, again so much common name, but we should know how it is there, what is this condition. So it occurs in middle-aged white men usually, but multi-system disease, and again symptoms are diarrhea and steatorrhea. There is weight loss and arthralgia, CNS and cardiac problems may be associated. This is due to bacteria, Tropharima whippeli, giving the name to Whipple's disease. So it is insidious onset, all malabsorption usually insidious in onset, and clinical features same only. Sometimes there may be arthropathy, ophthalmic and CNS involvement be there. So diagnostic is past positive macrophages by biopsy in lamina propria of the small intestine, There will be pass positive staining wheel order and pass positive macrophages in the lamina propria of the small intestine, and sometimes T. villi containing macrophages may be seen in the biopsy. Villi are also widened and flattened. So this is the diagnostic biopsy. So treatment again prolonged course of the because it's due to bacteria, again give some antibiotics, ceftriaxone or Septran single dose, single strength tablet 1 BD for 1 year. If it is allergic to Septran, you can try chlorphenicol. So sometimes bacilli after the macrophage is indicative of persistent infection or recurrence. So thank you very much.